Hi. Welcome to the McSwain Trauma Third Education Project Third Thursday Trauma Talk. We appreciate you all taking the time out of your Thursday evening to join us. Tonight we have Will Chapleau, the chairman of MTEP, and Steve Mercer, the treasurer of MTEP, and our honored welcome guest, Peter Pons, here to discuss EMS literature. Thank you, Dr. Pons, for being here. It is quite an honor and we appreciate it.
Thanks for having me.
Steve, I'm going to turn it over.
All right, well, thank you. I want to echo Mary's welcome to everyone. Welcome back to those people that have previously participated in the MTEP Thursday night, the third Thursday trauma talks, and welcome to all the new participants in there. Hopefully you'll continue to be part of the trauma talks as we go through here. As Mary indicated, Will Chapleau is going to be riding shotgun with me this evening during this process. And then we also have a behind the scenes person, Ms. Madison Noble, will be running things behind and keeping an eye on the features as we go through here. One of the things that we would like to ask is, again, because of the number of participants, we'll keep everyone muted throughout the process just to decrease the background noise. If you have any comments or questions or things like that, please use the chat feature that you can find in the dashboard, or raise your hand, and Miss Madison will keep us attuned to what's going on in there throughout the evening. One of the other things that I would like to, again, always feel free to use the chat feature or raise your hand. The only thing I would tell you about the chat feature is make sure that if you're trying to have a private conversation, or if you're speaking to everyone, make sure that you have the right position selected in there, that chat feature. Okay. With that, Ms. Madison, do we have the survey that we can do real rapidly? Okay, what we have here is a brief survey. If all of you will please take the time period to identify what your profession or your licensure is here. And again, if you hold multiples, just please indicate the highest one that you have. And if you just go ahead and make a selection and then click submit, so that we can, what we'd like to do is just get an idea of the level of individuals that are attending these talks and everything, so that we can make sure that we address all of those individuals in here. So again, if you just take a few seconds here and complete that survey, and then Ms. Madison, if you just let me know when you gotten a pretty good response back. Okay. While that's going on, let me just kind of do a brief little survey why we're doing this. This evening. If you remember, during last month's Thursday Trauma Talk, we discussed the National Model EMS Clinical Guidelines with Dr. John Kramer, who I happen to see is in the audience again tonight. Thank you, Dr. Kramer. But during the discussion, Dr. Kramer indicated that the committee who developed the guidelines for the National Model EMS Clinical Guidelines followed evidence-based research whenever available. Well, since then, we've received a couple of inquiries from individuals and everything that wanted to know a little bit more about EMS research, or just research in general. And if it's all good research, if it's all bad research, how do you tell the difference? And how do you get started understanding research? So with that, this evening, we've invited Dr. Peter Pons with us to have this discussion. Dr. Pons has presented on EMS research and article reading at various EMS conferences in the past. And he gets bombarded by Will and I on a regular basis about research in there. But I got to tell you, I'm a firm believer in the process and the way that Dr. Pons addresses research. And I think that you're going to find this to be a very, very knowledgeable, or you'll walk with a lot of knowledge in regards to research and how to evaluate research. believe it or not all research is good in there. So just a couple words about Dr. Pons. Dr. Pons is a board certified emergency physician that resides that operated in Denver, Colorado, lives just outside of Denver, Colorado. And he's been actively involved with pre-hospital care and disaster preparedness for over 40 years. He was the EMS medical director for the 911 paramedic ambulance service in Denver, based at Denver Health. In addition, he has served as the EMS physician director for the fire-based EMS systems of Glendale, Colorado, and Jacksonville, Florida. I dare say not at the same time. In there, he's also served as an educator and the physician director of the tactical combat care education programs, such as tactical combat casualty care, tactical emergency casual care, and tactical casual care for law enforcement and first responders. That's offered by the EMS education department by the Denver paramedics. He has published numerous peer-reviewed articles, journal articles on EMS. He's contributed many chapters for textbooks related to EMS and emergency medicine, and edited several textbooks for EMTs and paramedics. He served as a physician director for numerous mass gatherings and special events in Denver, including the Denver Grand Prix, World Youth Day, and the visit of Pope John Paul II. He's lectured nationally and internationally on EMS. He served as a member of the chair of the EMS community for the American College of Emergency Physicians, and he was a member of the board of directors for the American Board of Emergency Medicine. With that, as you can see, Dr. Pons brings a wealth of knowledge and experience to this conversation here tonight. And Dr. Pons, I got to tell you, thank you again for agreeing to have a little discussion with us tonight about EMS research and literature.
Sure, those intros though tend to put people asleep, so we'll hope we wake
Well,
them up.
yeah, I don't think so. Okay, so let's get started in here with this. And so again, for those of you that's new to this, what we're going to do is it's an interactive discussion. We'll post some questions to Dr. Pons, and he'll have some responses back to us. And every now and then we'll slip a slide in there to kind of make a valid point in here. Okay, so Dr. Pons, we know that the medical practice, whether you're in the hospital, out of the hospital, it should be guided by the medical literature found in professional journals, the textbooks, or physician consensus statements. Because the medical literature is written or authored by experts or researchers, can we assume that because the experts and the researchers wrote the article and it was published, that it's got to be correct and valid?
Well, as you stated in your intro, no. And I think that for anyone who has followed any of the medical reports related to COVID, we have seen an incredible array of information, misinformation, outright false information published. And so a key issue, I think, for every medical practitioner and provider is that you really need to look at the literature yourself. You can't just look at a summary that's published in a newspaper. You can't just look at a little paragraph that appears in an online news blurb, particularly true for EMS, unfortunately. And so we need to individually take responsibility for looking at what's published, critically evaluating what's published, and then analyzing the quality of that publication for its strength and robustness.
Dr. Pons, sorry, Steve, listening to what you just said there, there's a danger in just reading abstracts then, isn't there?
Absolutely. The abstract is the Reader's Digest version of the article, and the authors will put in it what they want, and that often leaves out important points that are found in the text of the article that don't appear in the abstract.
Thanks.
Well, one of the things that you talked about here is said that each individual should analyze an article for its strength and its quality. So let's kind of focus on that a little bit. Let's talk about, so how do you measure a published source for its strength and quality? is it based on our own judgment, or or is there standard way to measurement? Just because I think it's strong, does that justify it?
No, and it's hard to say there's a standard way. There are multiple ways to assess it, and a lot of it depends on the organization that is publishing the research, the organization that you work for. There are a host of ways to do it. But in general, we agree that there is high-level evidence, sort of mid-level evidence, and lower-level evidence. And it takes the form of a pyramid.
Well,
And
I think I just happen to have.
Yep. Great. And what you see here in this pyramid is at the top of the pyramid, you see systematic reviews, and just underneath that, meta-analysis. And that is considered really the highest level of evidence. And both of those are dependent on randomized control studies. Much of what we see in the EMS literature falls sort of in the middle of this diagram, with cohort studies, case control studies, cross-sectional studies. And unfortunately, a fair amount of it falls under the expert opinion rubric.
So maybe just a few comments on each one of the bands here to kind of help individuals understand the difference in between there. Can we start at the systemic review here?
Sure. Well, systematic reviews, what they do is you do a search of the literature for your particular topic. You're looking for high quality studies, which again are randomized control studies. And then you assess them. You put together the findings of these similar but separate studies, hoping to reduce bias, reduce random errors, and clarify what's known about the topic, what's not known about the topic, potential benefits and harms of particular intervention, et cetera.
Okay, so let's go to, what about the meta-analysis?
Yeah, the meta-analysis basically is you take all of those studies that you just found and you combine them and combine the results from them and do a statistical analysis to address the same question, but you're now producing a single estimate about the effect of the treatment or the study. And both of those depend really on randomized control studies. Randomized control studies are trials in which the participants are randomly assigned to one of two groups: the experimental group receiving the intervention or treatment that's being tested, and a comparison group or control group that is receiving an alternative treatment, maybe a conventional treatment, or even a placebo. And you're looking at these two groups to see if there are any differences in outcome. And the assignment to one of these groups should be random, meaning that you have an equal chance, if you agree to participate, of being in the experimental group or the control group. The results and subsequent analysis are used to assess the effectiveness of the intervention. And these trials, randomized controlled trials, are really the most stringent way of determining whether a cause and effect relationship exists between the intervention and the outcome. And obviously, ideally, we're hoping that the outcome is a positive outcome, but it may also demonstrate harm as well.
Peter, and again, Steve, I'm sorry for interrupting, but when you talked about the outcomes and the causes, that's another issue with studies sometimes, is whether or not the conclusion actually is able to show a causative relationship, correct?
Correct, and it depends on the type of study.
Yeah.
That's why the highest level is a randomized control study. The other studies that we're going to talk about suffer from that potential problem.
Well, And maybe another comment here, and I'm going to throw it in at this point. It just seems like a randomized control study in an EMS related incident is going to be very difficult because of the consent.
It is spectacularly difficult. And consent is obviously a major problem. To do randomized control studies, obviously there are very strict rules that are in place. And the requirement for consent is pretty rigid. Depending on the type of study, you can often, well, I shouldn't say often, you can sometimes get consent waived on the part of the institutional review board. But you're correct. It is really hard to do a high quality randomized control study in the EMS environment.
Right. And again, I think one of the things to bring up is the board, the internal board. You know, a lot of the EMS agencies in the United States don't have that. And it seems like a lot of the studies we see a lot of studies coming from international versus the United States, and is one of the reasons because of the stringent requirements for the randomized control studies.
That's correct. And the requirements, the strictness is less internationally than it is here in the US. We have the requirement that institutional review boards review every study before it's implemented. Consent sometimes can be waived, as I said. That often involves doing notices to the public in advance. It may require the use of a wristband that you either do or do not want to participate in the study. So yeah, it's tough.
Okay. Give me just a second here. I think we might have okay, I'm going to actually save her question here because I think we're going to get to it here and all. So I don't want to spend a whole lot more time on the randomized control studies and everything. Let's talk a little bit about the cohort studies.
Yep. Cohort studies are basically research studies that follow a group of people with a certain characteristic, a selected characteristic or criterion over a period of time. Often the study cohort is compared to another group of individuals who don't have that characteristic or criteria. It's generally a retrospective study, although on occasional studies that can be done prospectively, but it tends to be more of an observational study than a true controlled randomized study.
Okay. So what about case control studies?
Case control studies, it's a form of observational study that looks at factors that are associated with diseases or outcomes. You start with a group of cases which have the outcome or disease of interest. You then identify a second group of individuals who do not have that outcome or disease. They're the controls, and you're trying to identify what was common in the patients that had the characteristic or disease that is not found in the controls. And this allows you to at least hypothesize perhaps that the exposure or that factor may be linked to the outcome. And I think case control studies, and actually the next one we're going to talk about, cross-sectional studies, really what they do is they sort of set the stage for planning future, more rigorous, more advanced studies. And finally, cross-sectional studies. These, again, are observational studies that analyze data, criteria, et cetera, from a group of patients at a single point in time. They're used to measure things like the prevalence of disease, prevalence of health outcomes, understanding the determinants of health, and describing the features of a population. Unlike other types of studies, we don't follow these patients over time. It's essentially at one point in time. So again, these point to the need for additional studies because it's like what Will asked earlier. If you want cause and effect, these retrospective observational studies don't answer that question.
Peter,
Well, I think another important point about this that you've come up here with, especially from an EMS perspective and everything, is the importance of EMS data and the need for quality EMS data in order to do and to support these types of studies. I see Dr. Kramer laughing at me.
Absolutely. And the documentation that we ask for from EMS is often the part that is the most difficult for folks. Whether it is just the standard patient care report, they tend to get briefer over time as you get more experienced. But to do quality research, you need a lot of data and data points that are rigorously attended to, that are, you really are obsessive compulsive in your adherence to acquiring and reporting that data. And without it, we get nowhere. And the reality is that the EMS data is the first step in the overall patient data that we ultimately gather in the emergency department, in trauma centers, in burn centers, in stroke centers, et cetera. And it's literally the key to it all. EMS, I think, often does not have a good appreciation of how important its role is, not just in the aspects of patient care, but in data collection and in research, whether they're doing it primarily or the hospital is doing it subsequently.
I don't want to interrupt your flow here, Steve and Dr. Pons, but we're getting questions from the group too as we talk. And some of the things you're talking about, Dr. Pons, are being addressed. Monica Huber asked the group, her students taking EMS classes which are directed to find research topics only from credible medical sites and articles aren't necessarily accurate articles. So she's wondering, should professors vet what they're actually looking at? And do they even know what things are credible?
Yeah, well, let's talk about EMS students, EMS providers in general. We do, in general, and again, it's always dangerous to generalize, but we do an atrocious job of teaching EMS personnel the basics of research, what goes into research, how to assess research. It was part of the reason for doing a talk like this. And I think that every EMS education program ought to have a little time set aside and dedicated to discuss EMS research, how to assess it, et cetera, much as we're going to continue to do in this talk. And I think that to the extent that it's not able to be offered, then yes, I think an instructor should help guide their students in what is good research and not good research with some examples. And as we go through the rest of this presentation, I'll give you a couple of examples that, raise eyebrows.
Okay.
Thanks for letting me interrupt there. I think that was a good point to people that are following us along.
Okay, so let's talk about, let's go to the last band here, Dr. Pond, one of our favorites. The expert opinion.
What can I say about expert opinion? That's
I
when
have initials
people,
behind
that's
my
when
name,
people
so I
like
gotta
me, that's when people like me tell you this is how it ought to be, and you don't question it.
Okay, all right, well, good. Well, I think you, that's been a great job about talking to us about the quality of an article. I mean, the quality of an article and everything. I mean, the strength of the article. How do you figure out the quality of the article?
Yeah, well, there's a number of things you have to do. And again, as I mentioned before, there are a variety of ways that articles are assessed in terms of quality, and a lot depends on the organization that you're dealing with. I think perhaps most people are familiar with the American Heart Association schema for quantifying levels of evidence. And Steve, if you'll put up that, yeah. I don't know if you can read this or not, but the American Heart Association quantifies the level of evidence in terms of quality into 5 levels. Their highest level is level A, and that is high quality evidence for more than one randomized control study, a meta-analysis of high quality randomized control studies, one or more randomized control studies corroborated by high quality registry studies. And from there it goes down, and the triangle that we saw basically follows along with their levels of evidence. They group some of them together. And as you might guess, their lowest level of evidence is consensus of expert opinion based on clinical experience. Okay. And if you, regardless of whether you look at American Heart, if you look at a variety of other organizations, the AMA, the American Association of Neurosurgeons, the American Academy of Neurologists, the National Health and Medical Research Council, while they all have various combinations of the stuff you saw in the triangle, the reality is they all follow the same schema. The highest quality study is that RCT, the randomized control study. The lowest quality is expert opinion. And then depending on how they want to break out all the others, you end up with anywhere between 4, 5, 6 levels of quality for their purposes. The second column that you see is the analysis of the evidence. You look at the studies, you decide if they're level A, level B, level C, et cetera, and then you formulate your recommendations for treatment, intervention, et cetera, based on the level of the evidence. And the strength of your recommendation really depends on the quality of that evidence. And as you can see from the right-hand column there, this is American Heart again. Class 1, the green, that's strong strength of recommendation. Class 2 is the yellow and orange. Yellow is moderate. Class 2B is weak. Moderate, the evidence would suggest that the benefit exceeds the risk. The 2B, the weak, suggests that the benefit may exceed it or is equal to the risk. And then when you get to class 3, the benefit is really questionable. And the bottom one, class 3 in red, is when the studies suggest that in fact the risk far exceeds any benefit. So a lot depends on the organization that you're going to work with or for, but the basic schema is the same. Randomized control study, highest level, expert opinion, lowest level. All the others in that triangle fall somewhere in between. And then based on the quality of that literature, you can make a recommendation about what you want to do with some degree of strength. It may be strong, it may be intermediate, or it may be very weak.
You may have kind of answered this in that last bit you got into, but Dr. Kramer asked, how does reading an article in a peer-reviewed journal impact or reflect the quality of the science? Do we need him to clarify?
Yeah, I think I need a little clarification, John.
Can we give him, there he is.
Yep. Well, it was my backwards way of saying that or asking your opinion on, even if something is published in a peer review journal, it doesn't necessarily mean that it is a pristine study.
Oh, no. And we're going to talk about that a little bit more.
Sorry.
No problem.
No. Questions are always welcome there. Thank you.
So in fact, as I was saying earlier, I think every EMS provider should read published articles. And In order to do that, you have to know why you're reading it and how to read it. And ideally, as I sort of alluded to, the real purpose for reading a published peer-reviewed article is to distinguish useful therapy from information that is useless or potentially even harmful.
And that's where we have to coach, right?
I'm sorry, say again?
That's where we have to coach them, right? I mean,
But
particularly.
sometimes you have to coach them. Okay, so and in order to do that, you have to critically read an article. When I talk to folks about reading an article, the first thing I tell them is the first thing you ought to do is look at the title and see if it even interests you. If it doesn't interest you, throw it away. Don't waste your time. Okay. Then take a look at the list of authors. See if you know them. There are a number of authors in the EMS realm and elsewhere who clearly have a reputation for providing high quality research. And if you recognize that name, you may well want to read the article. And then you mentioned the abstract earlier. Clearly, it's worth, if you decide you want to read the article, look at the abstract, see if it really makes you want to read the full article. And then you need to consider the site that it is published, the source. You want to be sure that it is a peer-reviewed journal. And again, I think, unfortunately, in EMS, much of the information that is propagated to the average paramedic or EMT appears in online sort of newsletter journals that summarize the article in a paragraph or two and may or may not appropriately reflect the content. And then as you're reading the article, there are a number of questions to ask. Number one is this a randomized control study? Were the patients, in fact, randomized?
Oh, yeah.
I'm sorry?
Yeah, I mean, saying it isn't.
Okay. Then when they talk about outcomes, were all of the relevant outcomes reported? If you're looking at EMS literature, are the patients similar to yours? Did they consider statistical and clinical significance? And I'll talk about each of these in just a second. Then, is the therapy feasible in your setting? And were all of the patients who were entered at the beginning of the study accounted for at the end of the study? And these are issues that we always have to deal with. So the question of were patients randomized? Every patient should have the same probability of receiving either the test therapy or the control therapy. And the system for assigning them to that group should be similar to tossing a coin. Now, let me give you an example. Everybody, I think, in EMS should be aware of the CRASH 2 study that looked at TXA for trauma patients. And this was a study that enrolled 20 some odd thousand patients, with 10,000 in the TXA arm and 10,000 in the no TXA arm. And if you read the article, it says that this was a randomized control study. Well, as painful as it is sometimes, you have to read carefully the materials and methods of the article and the discussion. Because in this particular article, what they go on to say is that if the doctor is reasonably certain that antifibrinolytic agents, meaning TXA, are indicated or contraindicated, do not randomize. Okay. Now, this is the study that has changed practice. Okay. And if you read the entire article, nowhere do they tell you how many patients the physician said needed TXA and they reassigned them, or how many patients the physician said didn't need TXA and they reassigned them. Okay.
That's the North American struggle, isn't it? Trying to figure out how we can do randomized. How do you think when we did the?
But Will, this was not a North American study.
Oh,
In fact, it was done in 40 countries, excluding the United States.
What about the blood products one that they came up with wristbands and all kinds of stuff so people could vote on what they were doing or not doing? Does that compromise a randomized study?
No, because the wristband says you either want to participate or don't want to participate, but you have not been randomized until you're actually entered into the study.
Okay.
Okay. So, if you decide you wanted to get into the study, the wristband would tell someone that you are eligible to participate, and then you randomize them to which group they go into. Okay.
Thanks for
Sure. Then you want to say, okay, we're all clinically relevant outcomes reported. Another one of my favorite examples. Okay. If you look at the EMS literature on cardiac arrest and the use of epinephrine, okay, when we look at relevant outcomes, 9 out of 10 epinephrine studies in cardiac arrest report what outcome? Most commonly, return of spontaneous circulation, ROSC. Okay. Now, ROSC is generally a good thing, but is that the outcome we're most interested in? Or is it discharge from the hospital with reasonable neurologic status? Okay. Because again, if you take a look at some of the cardiac arrest literature, okay, the use of epinephrine resulted in a significantly higher rate of 30-day survival than the use of placebo. Okay, we had ROSC, but there was no between group difference in the rate of a favorable neurologic outcome because more survivors had severe neurologic impairment in the epi group. Okay. Are the outcomes reported the right ones? Question you have to always ask based on the study. If you're thinking that this study is something that we should implement in our EMS system, well, then you have to carefully read the materials section and the methods, because one of the questions you want to ask is, are the patients similar to the ones we deal with? So they ought to tell you clinical information, sociodemographic information, so that you can determine if the study patient groups are similar to the patients you deal with in your EMS setting.
Dr. Jeff Salomon just posted a comment, Peter. Isn't it strange in the AHA schema that both interventions that result in no benefit and those that cause harm are lumped together in class 3?
I refuse to get drawn into a discussion about the AHA. Nice try, Jeff. Now, the hard part, I think, for EMS providers is the issue of statistical significance and clinical significance. Statistics were all pain in the butt. And I think most of us are not well versed in the variety of incredibly diverse statistical tests that are done on patient groups. But one of the things to look at is, was the result, if they say it was statistically significant, ask yourself if it's clinically significant. And let me give you an example. Okay. There was a study that was done with a new blood pressure medication, and they entered like 2,500 patients, 1,200 in the blood pressure group, new medicine group, 1,200 with standard care. And what they found is that the new medication lowered systolic blood pressure by 3 millimeters of mercury in the test group, and it was statistically significant. Okay, great. Is that clinically significant? Do we care if it was lowered 3 millimeters? Okay. Evaluate the studies carefully. Then, again, look at the setting in which the study was done. Not just the patients, but the setting. Is the setting similar to yours? Is it available? Okay. And this is particularly important because in EMS, we often look at a study that was done in a hospital setting and say, yes, let's apply this study to the EMS world. And if you're going to be a purist, if the study wasn't done in the EMS setting, then you probably should not take the results and apply them to the EMS setting. So, pay attention. And then finally, were all patients entered in the study accounted for at the end? It's really interesting because looking at the charts that appear and the tables that appear in studies can be a royal pain in the butt. But you ought to look at how many patients were entered, how many patients ended up in each group, and see if group A and group B equal what they said they entered in the study. Because if not, then there were clearly exclusion criteria, and you want to know what they were. And sometimes a good study will tell you the specifics of what the exclusion criteria were. But oftentimes patients just disappear into the vapor and you just don't quite know what happened to the entire group. And these are all things that I think as you evaluate a study, you ought to be looking at them because they help you determine, is this a study I want to pay attention to or not?
I'm glad you brought up exclusionary criteria, because sometimes when you're looking at the study and you look at the exclusions, you're going, well, of course. I mean,
yeah, and a lot of them make a lot of sense, okay? Because many studies exclude pediatrics, many studies exclude pregnant women, many studies are going to exclude prisoners because you can't do a study, quotes unquote, an experiment involving prisoners, but exclusion criteria ought to be explicitly stated. And then they ought to be able to account for the number of patients that were excluded in their description of the total patient population. Now, we often look at other things as well, and we're going to talk about things like textbook chapters and EMS books and emergency medicine books, et cetera. And you look at textbook chapters and most of them are referenced. And I think one of the things that people don't do before they read the chapter is look at the list of references. Do they make sense? Were the criteria used to select articles for the chapter appropriate? Does it look like important studies were included or missed? Did they say anything about their assessment of the included studies? Okay. And are the results similar from study to study? Again, we give students materials to read, but we don't tell them how to critically analyze them. And I think this is a serious shortcoming in our education of EMS personnel. Steve.
Okay. No, this is just, again, we've had these discussions before and everything. I'm fascinated by a lot of this, and I may be a little obsessive compulsive in some of those areas in there. So let's go back and let's talk about reading an article. Let's say that I read an article that I'm really impressed with the outcome of it, with the conclusion. I think it needs to be added to our EMS agency, to its practice. So before I go to the medical director to propose this and get egg in my face and everything, what should I guarantee or be ensured about the article in there as I go to make my plea for this?
Okay. Well, one is hopefully you read the article and didn't just depend on the blurb
Conclusion?
that appeared online or just the conclusion or just the abstract. Two is, I think if you really want to make an impression on your EMS medical director, do a little bit of a search beforehand. See, are there other studies that support this article? Does the article talk about the benefits of the change that was made and the results in the system in which they're talking about? Does it talk about things like the cost of changing or not changing? This has huge implications in most of our EMS systems when you're talking about the financial impact of making a change in your system. And then you want to be sure with some of the things that I mentioned before, the clinical setting is similar to your setting. The healthcare system is similar to the study healthcare system. And, you know, do a little bit of work before you just come up to the physician director and say, this is wonderful, we need to implement it. And again, I think any physician director worth their salt shouldn't just say, get away from me, but instead should say, you know, give me a justification for why you think this makes sense in our system. And then you be prepared to provide that justification.
You
And
had a
I saw Jeff said it's sometimes not bad to get egg on your face. Sometimes, but the last thing I think I want to see happen is to discourage EMS personnel from reading the literature, from proposing new stuff, because the physician director really just sort of slammed them about it.
Dr. Pons, you talked,
I have some other, my past colleagues are on here and they know that I've had egg on my face on more than one occasion, and everything. So in there.
Dr. Pons, you talked about it's not enough for one study. How important is replication, or the ability for a study to be replicated?
Let me say, I didn't say it wasn't enough to have one study, because one study may well change practice. But I think ideally it would be nice to have supporting evidence as well. If you look at the TXA literature, for example, the CRASH-2 study has been the primary study that's been touted as the game changer for TXA. But if you look at do a search and do a critical evaluation of the literature, you'll see that the literature, in fact, tends to be not quite as positive as people would have you believe the CRASH-2 study is. And there are studies that conflict with certain conclusions with that of the CRASH-2 study. So I think, you know, it pays to look and see, is there confirmatory evidence, supporting evidence for what you want to do? Or, and the opposite is true. Is there evidence that conflicts with what you want to do, because you want to know that as well?
Good. Okay. Well, good. As we're getting down on our time here. So Dr. Pons, with all this is tremendous information and everything, and a tremendous experience. No, can you kind of summarize for us today's discussion about evaluating EMS literature?
Sure.
You know, just kind of condense it down. Give us
Sure.
a Reader's Digest example.
The abstract. You want the abstract?
Can I have the abstract?
Okay. Well, first off, I think that every provider at all levels should be reading the medical literature, the peer-reviewed medical literature. I think all of us need to critically evaluate the quality of the studies that we're looking at. And ideally, our practice would be based on high-level class 1 evidence to support that practice. It pains me to say that in EMS, much of our literature does not qualify as that because of the difficulties in doing randomized control studies. And the reality is much of our literature falls on the lower half of that pyramid that we saw earlier. We have a long way to go. It's tough to do, but that should not dissuade people from making the attempt. Without making the attempt, we will not improve our practice. And I think there are a lot of things in our practice that we need to take a look at and improve. So.
And I want to follow up with that. I think I agree with you 100% and everything. But one of the things that I think that we need to make sure that as we train our new EMS providers and things like that, is that this needs to be, our changes need to be based on scientific evidence, whatever possible, and everything, and not just an opinion in between there, or something that looks good, or the salesman says, or because I read it on the internet. You know, if it's on the internet, it's got to be true, you know.
Right.
in between there, and not to be afraid to enter into some of these studies in there, look at stuff in between there. You can do it from a local basis and then move on into regional or state. There is a plethora of data out there that, and I'm going to put Dr. Kramer on the spot here again, just if you can kind of say a few words about the National EMS information systems that everybody puts data, that there's a lot of data sitting out there for some cohort studies and everything that could be looked at in there. Dr. Kramer?
There is a phenomenal amount of data. I have to expand on one of Peter's points earlier. I mean, I think that unfortunately, there are two components to the electronic patient care record. There are the data elements and the drop-down screens, and then there's the narrative. And most folks, in a positive manner, have become more diligent about providing good documentation in the narrative, and then are of the opinion that because it's in the narrative, I don't have to include it as part of the the vital signs section, or how did I care for the patient? What medications did I use and what dosages? They both go together. The narrative is unbelievably important, but the data that is entered through the individual data elements really is critical to gathering the full picture to be able to do the kind of things that Peter has been talking about. So there's a little bit of a catch-22 there. It's critical to do a good narrative, but you also need to complete the other data elements to be able to appropriately, evaluate the system or conduct a research study.
Thank you. Thank you.
Dr. Pons, we talked about exclusions and other things you should look at in the study, methods. How important is it to look at the limitations that are described, or even to consider limitations that might not have been described?
Yeah, it's very important, because oftentimes the authors will do some of your work for you by pointing out the limitations that they have identified. And so, take a peek at that part. It's usually the next to the last paragraph in the discussion of the article, right above the summary, usually. But it's well worth taking a peek at those. And they may or may not be complete in their assessment of the limitations, but it's a start. And for those who are not used to looking at the literature critically, this provides a good intro, if you will, to doing that.
It also reflects in the limitations how candid and open the authors are about their study and their conclusions.
Yeah, if they don't mention that only having 7 patients is a limitation, then they're not being very honest.
The other thing I would mention to folks is it's also worth taking a look at the subsequent letters to the editor regarding the study. One is they can be quite entertaining. 2 is they often point out salient points that are not necessarily always discussed in either the discussion part of the article or issues with the patient population, et cetera.
You find those to be stronger and more prevalent in the traditional journals versus the online journals?
And by online journals, I assume you're talking about some of the EMS, more newsy journals. And the answer is yes.
Yeah, like the old timers, the old traditional print versions usually have several pages in the back of the journal where they have these comments, which are
right
good to dig through. Yeah.
I got another question posed to us and everything. So how do you engage the new generation of providers to actually look at studies versus the latest social media or podcast influences throwing out there as science?
That's from Catherine Lovgren. Thank you, Catherine.
Yeah, well, I think part of the problem is that when we teach our new EMS provider, we hand them a book. We say, this is what you need to know. And we seldom talk about the background of what went into that book and why what's in that book is there. Almost every paramedic book that I'm aware of, at the end of the chapter has a list of references. I would be astounded if any instructor ever pointed to those references, discussed those references, or in reviewing material from a chapter or a lecture actually said, here's where this came from. Here's what you should have taken a look at or questioned. And I think that is a failing of our EMS education that is long overdue to be corrected.
Dr. Pons, one thing we haven't talked about, and particularly for our students, who have a hard time getting access to the literature or having guidance when they're reading it. We've got several people here. Dr. Kramer's been involved in literature reviews. Dr. Salamone has been involved with literature reviews with EAST. We do literature reviews through the International Pre-Hospital Medicine Institute. We publish monthly. What do you think the value of literature reviews are, particularly to this audience that's trying to get a handle on science?
Yeah, my personal opinion is they should serve as a teaser to get you to want to go to the article. I think literature reviews, again, you're taking a multi-page article, synthesizing it into 2, 3, or 4 paragraphs. You may be writing a commentary about it at the end. The commentary reflects the individual reviewer's biases. So my personal opinion is that they should serve as a reminder, as a tweak to say, here's an article you might be interested in looking at. Here's why. Go get the article.
Agreed. So like for people who aren't reading literature, at least like gives them some indication that there's stuff they should know about.
And an incentive to take a look. There's more out there than just your paramedic book.
Yep.
Yeah, and I think, and again, even though we've been in the business for a while, we need to continue, not just the new people, but all of those, even the seasoned veterans and everything need to be continuing to read the articles and the information out there too, as that could dramatically have an effect on how things are going to go. And a seasoned individual may have an influence on the newer individuals too, in helping digest and read some of those articles in there too. So. Yeah. All right, we're getting here towards the end and everything. Again, if you have any questions or anything in this, you can always post, if we don't get to them this evening and everything, you can always pose them to us through the webpage, through the MTEP webpage. And with that, I'm going to turn this back over to Miss Mary McSwain for a couple closing comments about the McSwain Trauma Education Project, or what we refer to as MTEP.
Thank you, Steve. Look, I appreciate it. I was trying to answer Catherine's question or statement that medics out there don't keep up with the evidence that's been put out there, and agreed. And one of our objectives that we want through MTEP is to educate and empower EMTs to read the data and to understand what it means and how to use the data for their benefit. EMS is a redheaded stepchild, and it's never looked at as something that needs to be respected or entertained. And this is through data and through journals is a way that it can do that. We certainly appreciate Peter Pons and his wealth of information, and would like to have him come on again soon. Cancun will be next month, December the 2nd. We will have our second conference and first international conference in Cancun, Mexico. A special thanks to Aunt May and Uncle Neil, Daddy's sister and brother-in-law, for being here, as they have been every week faithfully. We appreciate your being here. And we rely on donations to keep us alive. In the past week, we have had $7,000 worth of donations, and we certainly appreciate that. And thank you to everyone who is here, and Jeff Salamone and Jeff Kramer, John Kramer, can't even get the first name or the last name right. So thank you for being here. And Peter Pons, as always, it's a pleasure. For December 22nd is our third Thursday trauma conference, but we've decided not to do it on that with the holidays. So we will look forward to seeing you again in January. Please monitor our website for upcoming events. And again, thank you so much for being here. We appreciate it. Will and Steve, thank you for being great monitors as always.
Thank you. And again, Dr. Pons, thank you, thank you, thank you. And thank you
Nice
to
job,
all the
Peter.
participants and
Madison,
everything.
were there other questions that we're going to ask?
No,
I
that's
don't-
it.
We
Okay.
don't have any other questions at this time at all. And again, if, as always, if anybody has questions offline or anything like that, contact us through the webpage and everything, and we'll see that they're addressed in there.
And look
And-
for us again on the third Thursday of every month, with the exception of
Look-
December.
Yeah.
We're here third Thursday of every month.
Look for us in 2023.
And
Okay.
please let us know what topics you're interested in 2023. We are here for you. It's not about us. We are here for you. Tell us what you want to hear, what you want to know about, and also conferences in your area. If you are interested in conferences in your area, or you can put us in touch with people who would be interested in having us, please let us know.
Thank you.
Thank you.
Enjoy the evening. All right. Thank you.